So, greetings everyone. My name is Jean-Pierre Kikens from Covexit.com, and I'm extremely pleased today to be with three distinguished gentlemen, two from Germany and one from the US. Dr. Derwand, who is going to be our main speaker today, but we have also the pleasure to welcome, of course, Dr. Zelenko, who is well known to all of you, and Dr. Martin Scholz, who is a co-author of that study that was recently published, and that is the topic of the webinar. So, as you probably know Dr. Zelenko very well, you probably don't know Dr. Derwand and Dr. Martin Scholz. So I will ask Dr. Scholz maybe to present you briefly, and hopefully Dr. Derwand will be back.
Yes, welcome everybody. Just two sentences. So I'm affiliated with the Heinrich Beschein University in Düsseldorf, Germany, and my background is immunology and virology, and we studied a lot of also coronavirus in the past. And I founded the company Leucocare in Munich, and which is a biotech company. So I give on to the other ones.
Okay, Dr. Zelenko, maybe while we are waiting for Dr. Derwand to log back into the session, you may want just to tell us a few words about your activities today and also the state of your health.
Sure, thanks for having us. I'm Dr. Vladimir Zelenko. I'm a board-certified family physician in the state of New York. And I, in early March, was forced to deal with probably the largest and earliest outbreak of COVID-19 in the outpatient setting, and developed a certain treatment approach, which is going to be the topic we discuss. And I was privileged to collaborate with Dr. Derwand and Dr. Scholz, who are world-renowned researchers and academic physicians, and they really helped and educated me how to bring this data to the world. And I have a tremendous amount of gratitude to them. The state of my health is it's better. Thank God I feel better. As you know, I was diagnosed with pulmonary artery sarcoma, which then recurred. I had open heart surgery. I'm on chemotherapy now, which has its complications. But overall, I feel very, very well, thank God. Thank you for asking.
Thank you, Dr. Zelenko, and Dr. Derwand is back with us, so hopefully we will be able to overcome the technology. So Dr. Derwand, why don't you tell a few words about your professional background?
Jean-Pierre, thank you very much. Good morning, good afternoon, good evening to everybody on the line. My name is Roland Derwand. By training, I'm a physician. Did my doctoral thesis in cardiovascular physiology, but since a longer time, I work as a physician in the life science industry in national, European, and global responsibilities. And I'm glad that together with Professor Martin Scholz and Dr. Zelenko, we were able, as you will hear also in the webinar, during the course of the pandemic, to build this team to analyze the first COVID-19 outpatient data and to publish it and to discuss the data today with you. Happy to be here. Thanks for the invitation again.
I'm really so flattered to have the three of you on this webinar. And I'd like to mention that this concept of early treatment is still very little implemented, especially in industrialized countries. But there is kind of a breakthrough, I think, maybe in the US with this hearing next Thursday at the US Senate. So there is a committee of the US Senate that is going to listen to exactly the topic we are going to talk about, which is this early treatment with treatment protocols like the one used by Dr. Zelenko. Sorry, anyway, our website features all the details about that hearing, and it will be possible apparently to watch it live on the website of the US Senate. So from this, I think it's time to give the floor to Dr. Derwand, and he's going to make a presentation of about 45 minutes. And then we'll be able to move to the Q&A, and I will then bring Dr. Schultz and Dr. Zelenko back into the conversation. That's a good plan?
Right.
Okay. And here we go. Dr. Derwand, the floor is yours.
Thank you. I have the screen. Everything looks good. So welcome to our webinar with the title, The Zelenko Early Treatment Study, the Role of Zinc and the Therapeutic Approach to COVID-19. Also, let's say in a short summary in Germany. Next. Just my conflict of interest, my engagement and contribution to COVID-19 research, including all related publications, and especially the study we are talking today about, has been private and independent from my employer. Next. Here our agenda. At the beginning, maybe a few words about the arrival of SARS-CoV-2 in Germany. Probably not everybody knows this story. Then a few details why zinc and why this group then also came together. Then, of course, we will talk about the Zelenko protocol and the retrospective case series studies we published recently. Then, as I said, a short update. How's Germany doing currently in the pandemic? Are there perhaps, when we think even of guidelines and recommendations, how to manage outpatients and inpatients, better examples somewhere in the world? And at the end, also a short conclusion, what is still missing in COVID-19, and as we just heard, is also more and more discussed among physicians, scientists, and even politicians. Next. So how and when did SARS-CoV-2 arrive in Germany? What is quite interesting, I mean, I'm just in the Munich area in Germany, and just a few kilometers away where I'm sitting now, there was patient 0 arriving, indeed a Chinese resident visiting the headquarters of her employer in the Munich area from January 19th to 23rd this year. And just before, obviously, she also saw her parents from Wuhan. And so patient number 1 in Germany was a colleague of her, a male 33-year-old employee of the company with a confirmed SARS-CoV-2 infection after having had symptoms of like a common cold before being diagnosed and confirmed on January 27th. The company reacted very well, also not used, of course, to this kind of crisis management, but they completely shut down their headquarters for the next 2 weeks. What was for sure key for the success to control, let's say, the pandemic in this company and in this area. And between January 27th and February 11th, 16 cases of COVID-19 were indeed identified in this cluster, emerged in 4 transmission generations. So these patients were then isolated in a qualified hospital, mostly demonstrated a mild course of the disease, symptoms like headache, aches, shortness of breath. 2 patients only had pneumonia, and the documented mean incubation time was 4 days. Next. All this data in detail, by the way, including viral load and the development and management of this patient, was then also quickly published in Nature in May 2020. And if you're interested in, I can only recommend to read this publication about the first patients, how they were managed, and about also the very comprehensive and interesting findings. Next. What we learned quickly in the pandemic in terms of pattern of the disease progression, that obviously 80% of the patients are showing mild to moderate symptoms. And maybe that was at the beginning an issue of the pandemic also in Germany, because young people were told that this is not probably so relevant and more relevant for the older patients. So in terms of spreading the infection, early of the year, probably different recommendations would have been more favorable. Nevertheless, we learned quickly also that 20% are suffering from severe disease and even critical disease, being at a much higher risk of death. And this proportion of 20% is becoming again interesting when we come also to the results of the publication and the treatment of patients by Vladimir Zelenko. Next. So how about the age and comorbidities of COVID-19 patients? Also a quick learning. I was, as a physician, very interested at the beginning of the year to read the emerging evidence publication, etc. So here a summary of more than 5,000 patients in the New York City area, demonstrating that of hospitalized patients, COVID-19 patients, demonstrating that these patients were older, had many comorbidities, as you can see in the second red box. And on the right, you see, of course, the typical distribution you would expect in terms of comorbidities when it comes to hypertension, coronary artery disease, heart failure, but also metabolic disease, obesity, and diabetes. So basically, we are talking about a high-risk population being older and demonstrating typical risk factors, as you would expect also in primary care when you see these patients. Next. So the question is, why zinc? And for example, why got I involved in being, let's say, more interested in and doing some more desk research and so on. And the truth is, to be very honest with you, that just December 19, I met a very good old friend from medical school, and she's an expert, let's say, in zinc, how you measure zinc, the relevance of measurements, supplementation, and so on. So I think I had a basic knowledge about zinc, but this longer conversation with her also about other topics, of course, I remembered very well. When it came to the comorbidities, as well as to the risk of these patients in terms of these coronavirus infections, the question really then came up, might zinc play a role? If we go to the next. So how about zinc deficiency? Zinc deficiency indeed was before confirmed in a large number of healthy elderly, and not only in development countries, but even in the Western world. There's enough data available. I thought it was interesting that zinc deficiency was also confirmed in the literature in diabetic patients. And concerning my industry background as a physician, I knew that antihypertensive drugs like hydroxychlorothiazide, angiotensin-converting enzyme inhibitors, as well as angiotensin-2 receptor antagonists, can indeed result in increased urinary excretion of zinc with subsequent systemic zinc deficiency. And of course, there would have been for sure a lot of other parameters, indicators, whatever. But nevertheless, I found that very interesting sitting, let me say, there reading literature, that age comorbidities and relevant co-medications align very well with the majority of described COVID-19 patients being obviously at high risk of the disease. Next. The question was, what are possible effects of zinc when, for example, used as a supplement? Zinc, of course, is known to be needed for an effective antiviral response. It is well known that zinc elicits activity against several viruses, as published for hepatitis E virus. And there were also publications showing that zinc inhibited the RNA-dependent RNA polymerase, and that also zinc ionophores block coronavirus replication. Next. Zinc ionophores are in general defined as substances which are able to transport particular ions across a lipid membrane in a cell, as you all know. And I was also aware of the publication that chloroquine is a zinc ionophore. And so I was thinking, I think it was end of February probably, and then beginning of March, if chloroquine and probably hydroxychloroquine might increase intracellular zinc concentrations in COVID-19 patients, and that this might be perhaps beneficial. So that was a time, I mean, when you sit there with your own thoughts, that you need to pressure test them. When I got into contact with my former colleague and friend, Professor Martin Scholz. Next. And we were discussing this concept and then decided that it might be so interesting that we should probably write it down as a hypothesis paper. And this is exactly what we did in March, as quick as possible, and published it in Medical Hypothesis with the title, Does Zinc Supplementation Enhance the Clinical Efficacy of Chloroquine or Hydroxychloroquine to Win Today's Battle Against COVID-19? By doing so, thank you, by doing so, publishing it as a preprint first, and then after peer review it when it was finally coming out, we already got then into contact, or we got notice of and got into contact with Vladimir Zelenko, and we thought it would be a good idea to mention that there's obviously a physician out there in primary care treating his outpatients already with a protocol including hydroxychloroquine 200 milligram twice daily, zinc sulfate 220 milligram once daily, equal to 50 milligram elementary zinc, and azithromycin 500 milligram once daily. And we stated that it would be helpful to have a detailed analysis of these patients, what was ongoing or just started during that time, at least the idea started, to get more guidance for clinical practice on the one hand, but of course also for more clinical trials and hopefully even randomized clinical trials. In the conversation then with Dr. Zelenko, we decided to support his effort to analyze this data. Next. And maybe already here, I mean, Vladimir Zelenko, he was treating physicians, right? A lot of sick physicians coming with suspected COVID-19. He, of course, did not have the plan or idea to do any kind of study or publish data. So this was all coming up in discussions and conversations he had with also interested physicians and experts to see how this population looks like and what the outcome might be. And based on these conversations, as I already told you, we decided to support his efforts in terms of, for example, developing a protocol, putting a data matrix together based on de-identified data, analyze it statistically, and then putting together the manuscript, submitted first as a preprint, and then finally and recently accepted here as a peer-reviewed article in the International Journal of Antimicrobial Agents. Next slide. Exactly. So the aim of this exercise and effort was to describe the outcomes of the patients treated in this outpatient setting after early treatment with the triple therapy you already heard about, including zinc, rather a low-dose hydroxychloroquine doses and azithromycin. And this also dependent on risk stratification. So the setting was a primary care practice of patients with confirmed SARS-CoV-2 infection, and the patients included in this analysis were treated from March 18th to May 14th. We then decided to close, let's say, the database. Quickly, of course, the question was coming up, is there any group of comparison? I mean, as we said, Vladimir Zelenko, he did not plan a study and then treated patients. He took care about his patients. And then the question was coming up, can his data be analyzed? We talked, of course, to a lot of statisticians, as you can imagine. You could have taken different populations that were published, for example, New York City. But of course, all these would not have been comparable. And so the best denominator, let's say, we found was then public reference data, at least of the same community. And that data was then used. And as you will later see, of course, we did not have access to a lot of details of these patients, unfortunately. So this is, from a design perspective, a retrospective case series studies in the general practice setting. And SARS-CoV-2 was confirmed by PCR, but in the pandemic, many patients did not have access at the beginning to PCR testing. And in the analysis, also patients that were clinically diagnosed and retrospectively confirmed by IgG detection tests, as you will see in the flow, were also included. The advantage of this analysis for sure is that 100% of all included patients had a laboratory confirmed diagnosis. And I mean, when you go through the literature, even in high-ranked journals, there are examples with only 3% of patients who had a confirmed laboratory diagnosis. But here it was a decision also based on the protocol to include only 100% confirmed patients and not only diagnosis, for example, based on clinical judgment only. Next. Then, what is also important, not all patients with a confirmed SARS-CoV-2 infection and COVID-19 were treated, but Vladimir Zelenko was indeed applying a risk stratification. So there are three groups. Group A were patients older than 60 years, and these ones with or without clinical symptoms. Group B, patients 60 years or younger with shortness of breath, so first symptoms that probably the infection is progressing to the lower respiratory tract. And Group C, patients 60 years or younger, clinically symptomatic with at least one of the described comorbidities, as you find it here in the list and, of course, in the publication. The today so-called Zelenko protocol for these and only for these positively risk stratified patients was as described: zinc sulfate 200 milligram once daily, HCQ 200 milligram twice daily, azithromycin 500 milligram once daily. And this triple therapy was given for 5 days, and Vladimir Zelenko did not use an HCQ loading dose. The not positively risk stratified patients got standard of care to treat common upper respiratory tract infections and recovered at home, and of course were monitored, and in case of any increase in terms of severity of the disease, they would have come back or been referred to a hospital. Next. Further documentation included the demographics of the patient, the clinical symptoms, vital signs, main co-medications, including corticosteroids, and documented adverse events. Next. The defined outcome was COVID-19 related hospital admission as well as all-cause death during the defined time of follow-up of at least 28 days in the treatment group and also in the untreated control group as public reference as available. Next. So this is an important figure, and we should spend some time on that one to really understand which patients were stratified, treated, selected, and also included in the analysis. We got, of course, a lot of questions when the manuscript was already available as a preprint. So in this community, when we stopped inclusion of, let me say, more cases in the analysis, 712 patients were PCR confirmed COVID-19 cases. 335 of these presented as outpatient in the primary care setting at one general practice. And after the risk stratification, 208 of these patients did not meet the risk stratification criteria, got standard of care, and recovered at home. 127 of these patients got the triple therapy. And in the analysis, we excluded 23 patients because we saw that they did not meet the risk stratification criteria, but were obviously treated for other clinical reasons. But to be consistent, of course, in the analysis, we were not able to include these patients. And indeed, many of them were also younger patients. So we had 104 patients available, but as of course time was running, many patients were also treated based on clinical judgment to protect them. And afterwards, these patients, at least some of them, were IgG tested. And 37 of these patients who also met the risk stratification criteria and had a positive IgG test were then included in the analysis, ending up with a total population of 141 patients positively risk stratified in accordance to the defined criteria and treated with the triple therapy. In comparison to 377 patients, the outcome was available in this community. Next. How about the baseline demographics of the three different groups? As you can see in the table, Group A, remember the patients older than 60 years. Group B, the younger ones with shortness of breath, and Group C, the younger ones with comorbidities and symptoms. As you see a typical distribution in the older patients of hypertension, hyperlipidemia, diabetes, and obesity. You see, especially in the patients with shortness of breath and younger than 16, Group B, 19% of patients, for example, with asthma. And concerning Group C, you see a relatively high proportion with 42% of patients with obesity. Next slide. How about the reported days since onset of symptoms? Indeed, these patients, as we will see also in comparison to the literature, were treated very early with a median after 4 days. Next. The clinical symptoms reported, the most often reported symptoms were cough and dry cough. Followed by fever, then of course a relevant number of patients with shortness of breath. And what was quite interesting to see also, I mean, let's say more or less still beginning of the year in May when we started the analysis, that there was a relevant group of patients with documented changes to concerning smell and taste. And with the number of 30% percentage for all patients, this fit very well to the reports in the literature during that time. And remember, I mean, all these patients were laboratory confirmed, and this can be almost used as a control when you read next time publications about these patient populations. Have a look if this is documented. Especially if they are not laboratory confirmed, this number provides a good hint, let's say, about this population and how many patients probably really had COVID-19. Next. Also very interesting, the vital signs, because, for example, the respiratory rate of these patients, but also pulse oximetry values were all in the normal range. So what does it mean? It means when these patients showing up in an outpatient setting, there's no reason to admit these patients to hospital, obviously. So these patients were still in stage 1 or stage 2A, as we will see on a figure later on. So they had COVID-19 confirmed, but rather still mild symptoms. And most of these patients worldwide during that period of time would have been sent home to self-quarantine and wait and watch. Next. Concerning the co-medications, as you would expect, in terms also of the demonstrated or documented comorbidities, included antihypertensive drugs, asthma medications, and 9% of patients took oral corticosteroids. These were not prescribed because of the COVID-19 diagnosis, but because patients had, for example, autoimmune disease. Next. What's the outcome of the study? What we saw in comparison to the public reference data, that treated patients were significantly less hospitalized, and we saw a numerical trend in terms of all-cause death. As you see in the paper, one patient in the treatment group died. And we also published some more clinical details about this patient. This patient was a cancer patient, was only able to take the triple therapy for 1 day, was then admitted to hospital, and unfortunately then deceased. Next. Here you see the odds ratios and the respective p-values, as well as the forest plot. Hospitalization, a reduction of odds of 84%, highly significant. All-cause death, reduction of 80%. And as I already mentioned, here, based on this analysis, not significant, but a clear numerical trend. Next. What is interesting, as I just mentioned, in terms of the analysis, the patients in the treated group, as you saw, were all positively risk stratified. The risk of the untreated control group was lower because this group included the high-risk patients, of course, most likely, but also low-risk patients, you can assume. I mean, we don't have the data, don't get me wrong, but nevertheless, this group of patients was not risk stratified. As we got a question, we compared the outcome of all risk stratified patients in the study group, meaning the treated and the non-treated patients, with the control patients who were not stratified, treated with standard therapy and recovered at home. And so when we take all these patients into the analysis, the not positively risk stratified and for good reason not treated, and the positively risk stratified treated with the triple therapy, we see a confirmation, of course, of the reduction in hospitalization, highly significant, but you then also see in this population a significant reduction of all-cause death. We did not show the data. This is included in the discussion only. We did not show the data in the results section because relevant clinical information, as you know, was not available for these patients in the control group to allow for any risk adjustment between groups. At least for any other, also maybe trials, etc., and settings, this might be another indicator based on this data. Next. Concerning adverse events, as documented, not a lot of surprises in these sick patients in terms of any adverse event, weakness, nausea, or diarrhea. For example, at first consultation, around 6% already had diarrhea, and here during the course of the treatment, 11% were documented, and rash with 1%. And what was important, no patient reported palpitations or any cardiac side effects. And patients at a possible risk for cardiac side effects, of course, did not get the treatment in this practice. Next. So let's come to the discussion. This first retrospective case series, this is the first retrospective case series study of COVID-19 outpatients in a primary care setting. And when we published it, it was indeed the first one worldwide to our knowledge, because all the other trials were done in a hospital setting. And the study results provides needed recommendation, as we think, for a risk stratification and an early treatment of patients to be able to prevent hospitalization and death of COVID-19, in addition to other pillars, of course, of the pandemic, like avoiding infections, number one, then also in terms of hospital management, and as a fourth pillar in terms of vaccine development. But so far, the early treatment of COVID-19 outpatients in the primary care setting was not in the focus. Next. It is known, and we have seen this in this patient population as well, that it's obviously critical to start the antiviral triple therapy as early as possible after symptom onset. Why? It is known that SARS-CoV-2 viral load appears to peak at days 5 to 6 after symptom onset, that severe cases progress to RDS after only 8 to 9 days. And it is established knowledge that an early antiviral treatment to manage severe disease progression is important, and was also shown for influenza in different publications. You need to treat early with your antiviral therapy that is available for influenza, as you know, because otherwise, with every day, the benefit is step-by-step decreasing in these patients. Next. The meantime, as you saw, was from symptom to treatment was only 4.8 days. The median was 4 days. And in previously reported time spans available when we did the analysis of the studies, ranged from 6.3 days to 8 days, up to 16.6 days when hydroxychloroquine then was still used, or indeed was even often not reported. And our hypothesis is that in many other studies, COVID-19 disease had most likely already progressed at the time of presentation to stages 2 or 2B and even stage 3 of the disease. Next. Early treatment is obviously important based on this data and more emerging observations, and underscores for sure the role of early intervention by primary care physicians before patients need to be hospitalized. And also what is important, that by applying the shown risk stratification approach, as Vladimir Zelenko did, the respective care was indeed tailored only to patients with a higher likelihood for hospitalization or fatality. So the result was that 62% of COVID-19 patients being risk stratified were treated with standard of care only, recovered at home, and only 37%, or let's say 38%, needed treatment with triple therapy. And when we go to the next, you see that the majority of patients did not need this triple therapy. And there's no need to treat all COVID-19 outpatients with zinc, low-dose hydroxychloroquine, and azithromycin. And when you remember the figure at the beginning of my presentation, that 20% are obviously then suffering from a more severe cause of the disease, and here 38% were treated. That fits somehow very well. Also, it's not directly linked. Nevertheless, you can see that definitely only a higher risk patient population was treated in this primary care setting based on the defined risk stratification, including 3 different groups. Next. What has to be taken for sure also into account, thinking of management of COVID-19 patients, is the long terminal elimination half-life of HCQ, and this has not been discussed very often previously. HCQ has a half-life of terminal elimination half-life of 32 days in plasma and 50 days in blood, and so the advantage of the triple therapy was obviously that the dosing approach, in comparison also to other studies, was rather conservative. The starting dose was the same as the maintenance dose, and only a short treatment duration was used of 5 days. Concerning the mode of action, I think you're all aware of that HCQ increases the pH, especially in lysosomes, inhibiting the pH-dependent SARS-CoV-2 replication, especially when it comes to entering the intracellular room out of the lysosome, and chloroquine and HCQ probably as well has characteristics of zinc ionophores, thus increasing then the intracellular zinc concentration. Next. However, the proper dosing of HCQ with its long half-life might be key for a favorable outcome of COVID-19 patients. Why? We have seen that in many studies with patients being hospitalized or even on the ICU, HCQ was used, and it is known and common practice that in critical care, drugs with a short half-life is usually preferred. So HCQ is probably not an ideal drug for severely ill patients on the ICU. Especially in these patients, critically ill patients, higher doses may have unforeseeable effects when it comes, for example, to insulin sensitivity in obese patients and also on glucose levels in diabetics. And it is also important to closely monitor renal function, which is increasingly affected during progression of COVID-19, because HCQ is substantially excreted by the kidneys, and the risk, of course, of toxic reaction is greater in patients with impaired renal function. And this makes the treatment of high-risk and severely ill patients with HCQ for sure even more difficult. Next. The dose of zinc was similar to doses previously studied to successfully prevent infections in the elderly. We already talked about the effect on the RNA-dependent RNA polymerase. But there's another hypothesis we propose and discuss also in the paper, that zinc might inhibit the serine protease furin. Furin is expressed on endothelial cells, for example, macrophages, smooth muscle cells in human atherosclerotic plaques, might play a critical role for the severe cardiovascular complications as well, but might be also responsible to favor spreading of SARS-CoV-2 compared with other beta coronaviruses. And as furin inhibition protects from certain viral-dependent infections, it may be important also to test the possible role of zinc inhibiting furin, so not only the RNA-dependent RNA polymerase, perhaps also furin, because this was also described at least once in the literature before, but is currently not known for SARS-CoV-2. Next. Azithromycin was added to the triple therapy and based also on the research Vladimir Zelenko did in terms of the literature research and information that was available during that time, based on preliminary data for more efficient or synergic virus elimination in conjunction with bacterial superinfection. Next. The role of zinc deficiency, I think I presented and explained already, but zinc deficiency might explain why certain patient groups seem not to benefit from HCQ monotherapy. And we will later see that there's also more and more emerging literature about this topic. Next. So also important during the 5-day treatment with the triple therapy, including hydroxychloroquine, no severe adverse events were observed, and no cardiac arrhythmia was reported in this general practice, what is in accordance with available safety data for more than 300,000 patients. And I think, as everybody on the line knows, that hydroxychloroquine is used for a long time, also in autoimmune disease in many patients. And of course, any possible, for example, a cardiac disease, etc., or complication needs to be ruled out before, and the patient needs to be monitored and followed. Next. What are the limitations of the study? I mentioned at the beginning of the webinar that, of course, that was not a blend prospective study, but very interesting data was generated when all these patients were treated. So that's a retrospective, of course, non-randomized and also not blinded treatment. We only had the outcome data for the public reference available, as I explained, so no adequate risk adjustment was unfortunately possible. confounding factor selection bias might exist. ECG for all the patients were not done and are not available. Then also triple therapy resulted in a numerically lower rate of all-cause death. In the absence of clinical details about the untreated patient group, the lower rate of all-cause death in the treated group was not statistically significant. And patients in the treated group were all positively risk stratified, as we have seen, while the risk of the untreated group was obviously lower, as this group included high and low risk patients. Next. What are important implications, nevertheless, of the study? Clinical experience, as I already mentioned, from severely ill patients with pneumonia who were treated with higher and sometimes much higher doses of HCQ or even chloroquine, is for sure not transferable to the outpatient setting and patients with upper respiratory tract disease only. For outpatients, with a short period of time, like here with after 5 days after onset of symptoms, COVID-19 represents a totally different disease and needs to be managed and treated differently. A simple to perform outpatient risk stratification, as you saw, allows for rapid treatment decision, in our opinion, and treatment with the triple therapy with zinc, low-dose HCQ, and azithromycin is obviously or can be beneficial. It may prevent a large number of hospitalizations and probably deaths, and this hopefully might help to avoid overwhelming of healthcare systems. And as we always said, of course, more data at the end would be needed. Next. Nevertheless, I mean, we all know how much criticized HCQ was in the course of this pandemic. And as I just mentioned, there's obviously a certain group of patients we already know, also from randomized placebo-controlled trials, that HCQ does not have a benefit. And this is obviously true for the severely ill patients. And this means here on this figure, probably patients with a stage 2B. This means patients with shortness of breath and already showing signs and symptoms of hypoxia. And you remember, in terms of the vital signs of the patients of our analysis, that none of these patients had a clinically relevant increase in the respiratory rate or a clinically relevant decrease in oxygen consumption. So I think what we can say is that for these higher risk patients admitted to hospital, probably already on the ICU, HCQ is not a good drug. However, based on our data and more emerging observational data, we see that HCQ, especially in combination with zinc, can have a beneficial effect, much more beneficial, or let's say beneficial in comparison to the high-risk group patients. And so the question is, why is there not more research done and supported in the outpatient setting since a longer time, right? I mean, these studies and investigations are still missing. We know high risk is a no-go, allow me to say, but with the patients at stage 1 and stage 2, with not such a progressed disease in a stage where antiviral therapy might be beneficial, more data would be appreciated. And based on the existing one, also more patients, in our opinion, could and should benefit. Next. What might be an additional role of zinc in COVID-19? I mean, there's more data published also that if zinc is added to HCQ, that mortality and hospital stays, the time of hospital stays is decreased. That treatment with zinc is associated with reduced in-hospital mortality. A new study coming out soon, currently available as a preprint, as you see here in bullet number 2. In terms of an analysis of the predictive factors for critical illness of COVID-19 during treatment, a relationship between serum zinc level and critical illness illness was shown, and also prediction of survival odds in COVID-19 patients by zinc-H and others showed a role of zinc, as well as there are first hints showing poor outcomes in patients with a zinc deficiency, for example, also at admission. Next. So this brings me back to Germany and the question, how is Germany doing in the pandemic? Next. And here you see the daily new cases in Germany after SARS-CoV-2 arrived. So in spring, we had then in March and end of March, also an exponential increase in daily new infections. And that was the time federal governments as well as then the government of Germany decided to go for a strict lockdown. That was basically, in terms of the new cases, successful, as you can see here, also in the decrease of the daily infection rates. We then did not see during the summertime a lot of infections. Later, after the holiday season or at the end of the holiday season, you see again a slight increase, also driven by tourists coming back to Germany. And as soon as we arrived in autumn, as unfortunately in many other countries, or you can say in Europe, in every country, we see again a tremendous increase in daily new cases. Next. In terms of daily deaths, I mean, in spring, of course, SARS-CoV-2 arrived, and the society was basically not prepared in terms of social distancing, safety measures, and of course, the infection hit all the different risk populations in Germany, not as bad as in many other countries, thinking here also of Italy. But nevertheless, I mean, the significant increase in deaths, of course, was also a reason to go for a complete lockdown in Germany, also having in mind the ICU capacity. We did better than other countries. I mean, Germany has still good access to hospital care. We have a lot of ICU beds. But as I mentioned before, ICU beds are probably not the only solution to the pandemic. You see, in accordance with the infection rates during summertime, not so many infections anymore. But now, unfortunately, again, increasing and again, raising concerns in our hospitals in Germany, when we might not have enough nurses anymore. So we have still a lot of beds available. But we also might run into issues if it is not better controlled, if we have enough staff available to take care about these patients. And that was the reason just recently the German government and also federal governments decided to go back again to partial lockdown. Next. Concerning the guidelines in Germany, and here I included just information about the medication that is accessible for any physician who is interested in. He goes to the link or to the links you see on the bottom of the slides, where usually these guidelines are published. There are certain drugs discussed, including chloroquine, hydroxychloroquine, and mentioning that there is not a lot of good evidence, focusing, of course, on the unfortunately late-stage studies. They discuss other drugs, ritonavir as well, remdesivir, to be used in which patients, also steroids, for example, and others. I think what is for physicians an issue in the clinic, if you are not at a university center, as at one of the big ones, that it is recommended to include for most of these drugs and therapeutic options patients in studies. Of course, in smaller hospitals, these centers do not participate in these studies. So there's unfortunately not a lot of guidance. For sure, in the big centers, they have their local guidelines, but this might be also different from center to center as we see it in different countries. Next. If we go to the outpatients, there is a guideline available for primary care, but it is stated that in terms of drug therapy, there's no evidence-based treatment option available. The only recommendation is for positively tested patients with comorbidities, already showing a significant increase in D-dimers to give prophylactic heparin. The guidelines focus on testing of patients, of management of patients in the doctor's office, and more or less on isolation of patients only, and when these patients should be transferred to a hospital. Next. So the question is, in terms of guidelines, are there better examples out there? I'm sure you are aware of many guidelines, maybe at your centers as well. But going through guidelines, personally, I found very interesting the one of Bahrain, the island Bahrain. And they started early with a very comprehensive guideline. Next. And this includes or tries to answer really most of the question of this pandemic, how to manage patients from diagnosis. They recommend, as we will see, a risk assessment and stratification of these patients. Very similar what Vladimir Zelenko did. They have a very concrete home isolation protocol in place, and they also have treatment guidelines in place, including also patients with mild to moderate symptoms. Next. So here you see the risk stratification, or risk assessment, patients that are contacting, for example, physicians and healthcare centers, when routine care is recommended, also concerning the testing. This means temperature less than 38 degrees. For example, no relevant symptoms, no shortness of breath, and normal oxygen saturation, and no chest X-ray changes. They recommend a test during the next 24 hours, only if the patients have any of the shown comorbidities, and urgent care if patients are showing severe symptoms like shortness of breath, chest pain, etc., as you see on the right. So here they have a clear risk assessment in place, how to manage these patients right from the beginning. Next. Concerning home isolation, I think also very interesting that patients need to meet certain criteria, like age less than 60 years old, only asymptomatic or mildly symptomatic, absence of risk factors, appropriate home setting for self-isolation, and so on. I mean, they are for sure in a different situation, like bigger countries. They have a population of 1.8 million. They have isolation centers when patients cannot isolate them at home, etc., and admit them then also to hospital if needed. But nevertheless, I think it's a very interesting also recommendation when it comes to home isolation of certain patient groups. Next. And in terms of treatment recommendations for uncomplicated infections, they do not recommend patients just more or less treatments like for common cold and to stay at home. They mention to consider the use of zinc, vitamin C, and vitamin D, and also the use of hydroxychloroquine if patients fit to certain criteria that are also defined in the guideline. Next. And indeed, let's call it a treatment protocol and not a guideline, I have to say. Nevertheless, concerning the dosage of medications for zinc, they recommend 50 milligram elementary zinc. Vitamin C, they have recommendations, and vitamin D. And hydroxychloroquine, they recommend a loading dose the first day, and then they continue until day 5 with 200 milligram twice daily, as, for example, also used by Vladimir Zelenko in treating his patients. Next. Concerning the indication for hydroxychloroquine, they recommend it for adults with mild disease or asymptomatic adults with risk factors early during the course of the disease. And I think there's a typo, so this means less than 7 days after onset of symptoms. Next. And if we do a comparison, how these countries are doing, I think we are all aware that there are a lot of differences between these countries, different situations. Nevertheless, I think it's interesting to look also outside the own country, what other countries are doing and how they are doing in the pandemic. You know about the example of Sweden, who did not have lockdowns and especially at the beginning, not specific measures in place in terms of cases per million. They have less cases per million than, for example, the US, but they have more than Germany and countries around them like Norway. Total deaths per cases, they have 3.5%, and they have been criticized very much. The US has 2.25%. Germany, we have less cases still per million than other countries, and also less deaths is 1.6%. As I mentioned, we had early lockdowns. We have for sure very good still hospital care and sufficient ICU beds available. That might have been one reason. And Bahrain is, on the one hand, a younger society, 11 years, the average age is lower. But from the beginning, they were suffering from a lot of cases per million, as you can see. But also in comparison, they have really not a high number of deaths, with the lowest death rate per cases of 0.39%. As I said, many factors playing a role, but seeing what they do since very early in the pandemic in terms of their protocol and recommendations, for sure that is or can be a good example also for other countries to follow, and not only to manage the pandemic by lockdowns and waiting for vaccines. Next. So what is still missing in COVID-19 from perspective also of this presentation and data? It would be helpful to have comprehensive guidelines available and with continuous updates, even in Germany, I have to say. Also, it is worthwhile applying an appropriate risk stratification of COVID-19 patients, having treatment strategies aligned for outpatients and inpatients, because these patient populations are different, also based on continuously emerging evidence. This might need also a shift of some government approaches, what has to be driven, like, for example, a more comprehensive guideline. And it is important to mention from our perspective that medical treatment for early COVID-19 patients will still be needed, even if an effective vaccine is available, as we see for the example of influenza. Hopefully, of course, less patients will be infected, will become sick, but the patients who will still contract COVID-19 should have also a treatment option very early in the course of the disease. Next. And with this, I want to thank you for your attention and being here, and I hope we still have time for some questions, including my co-authors of the study, Martin Scholz and Vladimir Zelenko. Thank you very much.
Thank you so much, Dr. Derwent. And let's move to the Q&A, but before, let's have a 30 All right. So here we are. And I think that it may be worth asking maybe Dr. Zelenko first, your feedback on the presentation and if you have any comments.
It was very informative. I learned a lot. I want to thank my two colleagues for really being instrumental in bringing this data to the world. As Dr. Derwent said, I wasn't doing research. I was just trying to treat people. And I didn't even realize the significance of the data. But it was the first data set in the world regarding COVID-19 outpatient treatment. And it actually been the foundation for other protocols. So I'm proud of how it's affected humanity on a large scale. Definitely not enough. We're still in the pandemic mode, but people are not dying from COVID-19. They're dying from ineffectual policies that are not getting the medication and the knowledge to the patients that need it. And hopefully these types of lectures and awareness will expedite the flow of life-saving medical information. That's what I have to say.
Thank you. What about Dr. Scholz? And make sure to turn on your microphone if you don't mind.
Yes, thank you, Roland, for this wonderful presentation. And as from the viewpoint of an immunologist, and I would just amend that clearly you presented clearly the urgency of the early treatment, and this is not only because to stop the virus, it's because also because you may impair the immune reactions that when they go on after a couple of days, they will come to the famous cytokine storm, which you cannot treat anymore, or almost not treat it anymore. For example, there's some researchers try to block interleukin-6 with an antibody, but it's very hard to manage the cytokine storm because it's such a complex system. You can only impair this immune reactions, this immunopathology in the early beginning of the disease, and this is what I would like to mention. And in addition, SARS-CoV-2 also manipulates the immune system slightly because it may infect the macrophages, which are basic instruments of putting forward the hyperinflammation, which may lead to death, and this is the point which I would like to make.
Thank you. Dr. Derwan, do you want to comment on those two comments?
No, I mean, as I showed in one figure, thank you. And as I showed in one figure, I mean, this disease has different stages, obviously, concerning the clinical course, and that is important. And the trials we saw with patients, including stages 2B and 3, and regimens based on hydroxychloroquine, we can see that these patients do obviously not benefit. But this is not only the case in COVID-19. This is the case in influenza. This is the case in varicella zoster infections when you want to treat them. I mean, we also mention the data in our discussion. The later you treat influenza with an antiviral drug, the higher the likelihood of patients being admitted to hospital. And this is an established principle in medicine. And it has not really been discussed during the pandemic. What is a little bit astonishing, and as we have seen, it is worthwhile, and the discussions are now more and more coming up to focus also on the treatment and put more efforts in terms on research on the outpatient setting, to having another beneficial and effective opportunity here to help patients to avoid hospitalizations and overwhelming, of course, our healthcare systems, societies, and at the end also economies, until number one, a vaccine is available. And as we have seen in infectious diseases, effective medical treatment is still needed when a vaccine is available.
Here is a comment by Beth Bowman. Maybe you want to comment on this? Dr. Derwan?
I don't see a comment.
Okay, this is so accurate.
I don't see a comment at the moment on my screen.
Okay. Anyway, I'm going to read it. This is so accurate in outpatient treatment. I'm seeing so many hospitalizations that are basically getting outpatient treatment.
So the question was, he sees patients, many patients being hospitalized with or without outpatient treatment. This I didn't understand.
It was not really a question. It was a comment that
Okay.
there are people getting hospitalized who are actually getting outpatient treatment. You know, like the treatment that could be provided on an outpatient basis.
Yeah, I don't know if Vladimir wants to comment on that from his perspective as a practitioner.
If any of my patients, thank you. If any of my patients end up in the hospital, I view that as a treatment failure on my part, because really no one should end up in the hospital. That's what the data shows. If you treat aggressively and early enough, then you help the immune system eliminate the viral load, and you, more importantly, prevent all the secondary complications, the inflammatory and thrombotic complications of the immune response. So the key is not to let it progress to get to the hospital. Once it's in the later stages, even if before the ICU, but once it's already past 6, 7 days, it becomes much more complicated to treat. And the effect of hydroxychloroquine and zinc and azithromycin is not as effective. At that point, if someone comes to my office, let's say, after 7 days of symptoms, and they look sick to me, I don't send them to the hospital, but I will also, in addition to the standard protocol, add steroids. I may use ivermectin as well, and I use anticoagulants. In other words, I try to bring the hospital to the patient instead of the patient to the hospital. But again, it all depends on the clinical presentation of when is the patient, where in the disease course is the patient. And the treatment plan has to be custom tailored to that. So the way the comment was made was that the patient in the hospital is getting outpatient management, which is great, but it's a little too late at that point. And they need much more aggressive treatment, and they may have already developed complications. So the key is to treat within the first 5 days, and I would even go as far as to say within the first 2 days, like the CDC says with influenza, that you should start treatment within 48 hours. So that's what I recommend.
Yeah, I'd like to comment on this. It's a recurrent theme, but I think it has to be emphasized. The treatment, in most cases, needs to start before the result of the test. Huh? That's correct. Huh?
Well, that was for sure the case in March and in April, where it used to take 3-4 days to get the results. Patients would come into the office on, say, day 4 or 5, and then we would get the results on day 8 or 9. By then, the patient was very, very sick. Now, fortunately, at least here in America, we have point-of-care testing, which gives you the results within 15 minutes in the office setting. That makes it much simpler. However, my only caveat there is the tests are not 100%, and I still rely on clinical judgment. I don't care what the test says. If the patient has all the clinical symptoms or has the exposure and some of the symptoms, I rely on my judgment more than just what the test says.
Thank you. I have here a question. Maybe Dr. Scholz may want to comment. What about other types of ionophores like quercetin or EGCG?
Yes, of course, it's a good question. So there are a lot of other zinc ionophores, and especially the zinc ionophore quercetin has also been shown to have antiviral effects and immune modulatory effects. And in my opinion, it would be very important to now test a row of this kind of also antioxidant and immunomodulating molecules, which might help pretty much in the early beginning of treatment. This is a good idea, yes.
Thank you. Dr. Zelenko, you want to comment on this? Your experience, for example, with quercetin?
Yeah, Yeah, I actually have a lot of experience with it. It's my plan B. What I mean by that is I prefer hydroxychloroquine because besides the zinc ionophore property, it has several other mechanisms of action which I find useful. As Dr. Schultz mentioned, that it has an ability to inhibit the cytokine storm. But even besides that, there's data that shows that it stabilizes red blood cells. It helps with oxygenation, which is one of the problems with COVID-19. And also, I believe it changes the pH in the endozymes or lysozymes, and it decreases the amount of virus that enters the cytoplasm, which also helps. So, in other words, it's not just one mechanism of action with hydroxychloroquine. However, since I live in the real world and live in America, where, especially in New York, where it's exceedingly difficult to get hydroxychloroquine, so I sometimes use quercetin or GCG because they're over the counter and patients can get them without a prescription. So it's better than nothing. However, with that caveat, since it's not as strong as hydroxychloroquine, I will use add-on drugs as well. So if I'm using quercetin, by the way, you have to use vitamin C. This data shows that quercetin and vitamin C need to be together for synergy effects. And I'll use zinc and I'll throw in an antibiotic. But because my confidence in quercetin is not as strong as hydroxychloroquine, I will add on ivermectin or inhaled steroids like budesonide or oral steroids like dexamethasone. So again, it depends on the clinical presentation. The key in the art of medicine is to treat each patient individually and custom tailor a treatment approach that is best for that patient. And I find that that's impossible to do with a cookie cutter approach. It needs to be done on a case-by-case basis.
Thanks. Actually, talking about ivermectin, maybe Dr. Dedwand, can you comment on the latest studies or your understanding of the role of ivermectin?
No, I mean, especially also hospitalized patients, the data is demonstrating a benefit in treating COVID-19 patients. And what you see among treating physicians that this option to be added to the therapeutic regimen, also with other substances or, as mentioned, vitamin D, vitamin C, is practiced by more and more physicians. That is what we see in conversations, let's say, behind the curtain somehow. Also, as Zev Zelenko said, when hydroxychloroquine is not available as an alternative, that it is more and more used and add to certain treatment regimens. But we have currently no data set available on our own we could refer to.
Okay. Here is a question regarding stratification. Oh, sorry, I'm getting the wrong one. Oh, sorry. The screen has moved here. Okay, well, let's go to this one. Can you just maybe, Dr. Zelenko, tell us about your currently recommended prophylactic treatment?
Sure. I'll tell you what I do. I take hydroxychloroquine and zinc without the antibiotic. And the recommendation that I give people is a loading dose of 1,000 milligrams of hydroxychloroquine, but split over 5 days. We find that mitigates or minimizes the side effects. And then after that, since hydroxychloroquine has such a long half-life, so for example, in malaria prophylaxis, the recommendation is either weekly or biweekly, the dosing schedule. So it's a very convenient drug, and I found that most people do very well with 200 to 400 milligrams once a week, together with zinc. Zinc, I would recommend 25 milligrams once a day. I think that seems to be sufficient. Besides that, if you want to, or if you can't get hydroxychloroquine, then I would use a low-dose quercetin, vitamin C, and zinc. So quercetin 500 milligrams once a day, has a short half-life. Vitamin C 1,000 once a day, and zinc 25. And then I have less experience with the green tea extract with EGCG, although I've seen data that it's even more effective than quercetin. And I use that together with 400 milligrams once a day with zinc 25 milligrams. Those are my recommendations for prophylaxis. It depends on the patient. Obviously, patients that are high risk, like nursing home residents or people that have high viral load exposures or people with comorbidities, those patients should definitely be on prophylaxis. The young, I'll tell you a very interesting clinical case that I have, which I was hoping that I could write up with my colleagues. But it's a case report that I had a family of 8 members. The husband has heart disease and severe Crohn's, immunosuppressive drugs, and he's pretty sick. He's young, he's in his early 50s. And but the wife and 6 children are healthy. So I decided to prophylax him alone. And it turns out that everyone in that house developed COVID, proven by laboratory testing, except him. And then 3 weeks later, I did antibody testing, IgG antibody testing. And everyone in that house had positive IgG, except the patient that I prophylaxed. He had 0 titer. So that's pretty convincing to me that it's effective. The problem is that I don't know if I want to prophylax the young, healthy people, because I want them to develop an immune response and develop an immunity, natural immunity to it, because 99.99 or 97% of patients in the low risk category will recover on their own. So there's no reason. That will take us into the vaccine issue also. You know, will we vaccinate these people? Well, the answer is, why should we? Just in case, just if you look at, for example, the shingles vaccine or the pneumonia vaccines, we give those to people over the age of 60 or 65. We don't give it to kids. So the question will be, with the COVID-19, either vaccine or prophylactic approach, who's going to get it? I'm afraid that they're going to mandate that people that don't need it will get it. I'm not going to give it to my children. I don't see why. Anyway, most of them had COVID and they're fine. But why would I expose them to a vaccine or even prophylaxis, for that matter, if they're going to get better on their own? Well, that's a real question.
If I may put a point here, I'm 2 things. One, I don't know if I'm young or old. I'm in the gray zone with the color of my hair. And but I'm also living in Canada, where there are strict prohibitions on hydroxychloroquine by the federal governments and the provinces, and it's a totally inaccessible drug. So I'm telling you what I'm doing. I take prophylaxis with supplements, with the idea that if I get infected, or when I get infected, I should have a better chance of having a milder form of the disease. That is my logic. And what do? I take quercetin, I take picolinate of zinc, I take vitamin D, vitamin C, and I do that regularly, daily, and that is my logic. Is this a sound logic that I'm adopting, as just not having the kind of hard prophylaxis with like hydroxychloroquine or ivermectin, which are prescription drugs here, but using supplements that may help me get a milder form or no form of the disease if I get infected?
Was that question?
No, I mean, maybe a quick comment, and what you're mentioning is more and more discussed. I mean, you saw in the presentation the populations that might in general suffer from zinc deficiency even in the Western world, and this includes especially the patient at risk like diabetics, patients treated with certain antihypertensive drugs, and Also, in the Western world, age is of course a risk factor. So, I mean, it is discussed, for example, on the NIH website in a very conservative approach. I mean, there's a lot of data out there, even with higher doses being supplemented in the elderly. Dr. Brassard in the US, who is here the key, has been the key expert in the field, has published a lot of interesting data. So to ensure, for example, that you have sufficient amounts of zinc on board, and probably it's not needed to take high doses, right? I mean, people can take supplements with a usual dose of zinc. Probably that would be better than not taking it and not being at risk of taking too high doses above the daily dose you need in general. But unfortunately, all these options, and let's call them simple options, are not really discussed also by experts. You mentioned vitamin C, of course, right? I mean, how many people in general take vitamin C in the cold season? Vitamin D, especially in autumn, winter times, many people can take. And as you saw, and that was exactly the reason why I included the Bahrain protocol. In other countries, this is a recommendation, at least for the mildly affected patients, but zinc, the populations could be at least made aware of this topic, and that might be already helpful. And this could have been also tested very quickly, also at the beginning of the pandemic, if there's a benefit. Having clusters, big cities, you recommend for a certain period supplementation, and maybe others not. I think there are a lot of people out there who might have had a lot of good ideas to test it better than I do. Nevertheless, I mean, it's still an open question, and there's no official recommendation out there.
I have here a question regarding risk stratification. And I'm just going to read it. In the latest Zelenko protocol, the high-risk group is over 45 years old. Earlier, it was over 60. Please explain.
So I have to apologize to my colleagues. I haven't had a chance to discuss it with you. But I've done kind of a research on the data, and I see that by lowering the age of what we consider high risk, we can probably capture another 15%, 20% of the patients that are being admitted in the hospital. And my colleagues here in America, Dr. McCullough and some of Dr. Villette, I think, Dr. Lee, they've reduced their age, what they consider high risk, to around 50. So since the treatments are so benign, and I want to capture more and more patients that are, and prevent more hospitalizations, I think it makes sense to tweak the protocol. Now, I believe that science and medicine is a dynamic, living thing, and our information changes over time. I think it's really important to be flexible and to be able to adjust what you do. Now, in early March, it was a war situation, I would say, where I had thousands of patients that were sick and no resources. So at that point, I was just trying to, I was triaging patients and treating whoever I can. And I wasn't even thinking about, tweaking things. It was just, let's just survive this wave. Now that things are a little bit more quiet and under control, I think it's very reasonable to reevaluate the approach that you're doing and incorporate other modalities as add-ons. So that's exactly, notice I mentioned that I started using vitamin C, vitamin D, ivermectin, steroids, blood thinners. So all these things have been modifications on the original approach. But again, the main concept of the protocol has never changed, which is high-risk patients. We can debate what that means, but still, we have to identify the high-risk patient and intervene early. That seems to be the more important thing than exactly what you do. It's the early intervention in the right patient that seems to make all the difference. And what we intervene with, I've seen effective modalities that I didn't think of initially. And then, so I have, my ego is, I could suppress my ego and internalize, incorporate other people's work as well. So I'm finding that I have been treating a lot of people in their 50s. There were, not as many as obviously in the 60s, but still, I think that it's reasonable to lower the, in my opinion, the treating age.
I have here a related question, which is about pregnant and breastfeeding women. Can they be treated with the protocol or another early treatment protocol?
Who's that question to?
Dr. Derwent,
yes, please go ahead. You have experience, right?
Oh, okay, Dr. Zelenko then.
So for 65 years, hydroxychloroquine has been used for various indications, rheumatological diseases and malaria treatment, malaria prophylaxis. And it's been given to women, pregnant women, to children, to nursing mothers. So the answer is yes. When it comes to hydroxychloroquine, zinc is just a mineral. I'm not aware of any contraindications. And azithromycin, for example, it's considered class B antibiotic, which means it's safe in pregnancy. So the answer is that it is safe. COVID-19 is not safe in pregnancy.
Here I have a question regarding zinc. Maybe Dr. Scholz, Professor Scholz, you want to comment? Is there a difference between zinc oxide and zinc sulfate? And I would like to add zinc picolinate from my own experience, because that's the one I use.
Usually the zinc sulfate is used, but maybe Roland Derwent has more experience about this in the medical field. Yeah. So it's better to refer to him.
No, I think there's a lot of discussion going on in terms of zinc and what you should use. I mean, we talked about the prophylaxis and maybe also in deficient people. There are different formulations out there. I would say for prophylaxis, it's fine. The patient take maybe what they even, or people take what they even used to. When it comes to the treatment protocol, I would stick to the zinc we have the data for. And when it comes to the Zelenko protocol, this is zinc sulfate. And I would then not recommend to change it. A different question is if it is, for example, not available, then you could switch to a different formulation because in pharmaceuticals we have seen so many differences when it comes to salts, etc., concerning the kinetic or even dynamic, especially in combination with other drugs. So I personally would be conservative and say if zinc sulfate is available, I would stick to zinc sulfate. Otherwise, there are other options available.
Maybe I can amend this because it's more important in my opinion to look at the time phase of the disease, and maybe it's not so important to have the zinc sulfate or zinc oxide, but it's more important to look what happens during the cytokine storm, and because maybe zinc is not any useful during the cytokine storm, during the later stage of disease, because it is known, for example, that interleukin 6 activates zinc binding proteins. So it's a very complex system, and maybe the immune system avoids zinc to come to the cell and to inhibit the RNAs, the virus replication, and so. But actually, we do not know much about this. So just to amend that, it's more important again to add zinc in any way, to supplement zinc in any way very early. And we have experience with the sulfate, as Roland Derwent mentioned.
Thank you. I have a question actually regarding your study, and I read quite a few French studies, especially from IHU Marseille. And when they were doing the inclusion of patients, they were not including patients who had received less than 3 days of the treatment, in the sense that they considered that if a patient shows up at the hospital and is very sick, and after it takes 1 day of treatment and then he goes to the ICU, for example, they don't include. But you included one patient who had only 1 day of treatment. So why did you include that patient? And if you had not included that patient, would it have had a difference in terms of your conclusions? Because I think you got statistical significance on reduced hospitalization, but you didn't get statistical significance on reduced mortality, even though numerically it's pretty clear that there is a reduction.
Now maybe I can I can start to comment. Of course, we before the analysis we defined a protocol for the analysis, and we strictly followed. And the difference is, for example, as we mentioned now many times, that Vladimir Zelenko, he was treating patients. I mean, he did not have any measure in place, for example, controlling that all these patients were taking every pill every day. But these patients got a prescription for 5 days. They were advised how to take the drugs, and also, of course, how to take care or be aware of possible side effects. And this, let's say, was the best quality we could guarantee in the analysis. There's more detail included in the publication, because some patients, for example, did only take zinc and hydroxychloroquine. Every patient took zinc. I think a few patients took also another antibiotic. But almost all of the patients, you can say, took the triple therapy. And as we were fully aware also of the weaknesses of the study, like the comparator, the control group, number one, we decided that we only include 100% laboratory confirmed patients, and we decided we include then all the patients being appropriately risk stratified, patients who qualified, who got the treatment, right? I mean, in a randomized control setting, it is like an intention to treat approach. And there was a lot of discussion, but we decided to deliver the highest quality possible, and definitely not to pick patients because they were not able to follow a treatment regimen. This can happen with any treatment and always, right? I mean, it doesn't mean that when you get a medication, there's a 100% efficacy. And when we included all the patients in the analysis that were not positively risk stratified, sent home, representing a rather equal risk in comparison to the control group, also the outcome, all-cause death, was significant.
Thank you. The study by Dr. Zelenko was obviously from patients in the US, but you are both, Dr. Derwan and Professor Scholz, in Germany. Did you have any kind of impact in terms of orienting policy in Germany? Are there people listening to the potential for early treatment, the potential for reducing hospitalization thanks to early treatment? Are you getting heard by the authorities?
I mean, maybe I can start, and Martin, if you want, of course, please feel free to add. Early in spring, we were in contact also with centers that initiated also taking part in the solidarity trial of the WHO, and having also own studies ongoing, discussing to include also zinc, for example, in one arm, etc. Unfortunately, there was not so much interest, despite the fact that we even tried to get funds to amend these studies. For example, we also tried to contact policymakers, to talk to other experts. But then, and it was the same situation in Germany, also probably concerning the media, like I guess in the US, that when these negative studies were coming out, it was just black and white, right? there was no real discussion and debate what risk these patients had, that these patients were already hospitalized, etc. And that was also one objective why we decided with Vladimir Zelenko to analyze his data and to publish it, because we recognized that this difference was not a discussion, when was not a topic among experts even. Then a lot of other trials were running in Germany, like, for example, with remdesivir, of course. And so quickly there was no big interest, and everybody was focusing on isolating patients and discussing the availability of vaccines. I mean, the first conversations or discussions in public were that a vaccine might be available in September. And there was not a lot of interest then focusing on therapies that might not be needed probably sooner than later. And now, after this data is coming out, and also additional pieces of evidence, we will also try again to talk to different stakeholders in Germany. But I think it is as difficult as in other countries, unfortunately. Martin, do you have to add something?
Not much. You described it very precisely. So, but maybe it's to mention, in my opinion, there was a cut in the interest also after the publication in Lancet came out, which they concluded this. There were two publications. They concluded that the hydroxychloroquine has a negative impact on the patients, and no efficacy or no benefit. And this was the time, even when we spoke to colleagues, they said, "Oh, hydroxychloroquine, no." It was shown that it's rather damaging. It has damaging effects and no positive benefits, etc. And yeah, it's even in the field of in the university field, the people are looking for big publications in big journals like Lancet or New England Journal of Medicine, like this. And so it's very difficult to come through with an alternative opinion.
So what about the impact of the Solidarity trial results, at least the provisional results that were published about remdesivir? Because I saw that remdesivir is part of the kind of treatments provided in hospital, but it was shown to be ineffective by that large clinical trial.
Yeah. No, it's a very good point. I mean, at the beginning, when the first press releases were out some months ago, I mean, it was announced as the new standard of care, as we all know. I have to say, based on the for sure limited conversations I personally had, that there was not a lot of enthusiasm about remdesivir. And it was also limited, of course, to a certain group of patients. And after the data of the Solidarity trial, it is even considered in a more conservative way as a treatment option in hospital levels or for hospitalized patients. So it is really debated and discussed, and only a little benefit is perceived.
Actually,
may I add my commentary on that? So remdesivir was used because of remdesivir, the use of outpatient, cheap, generic modalities were being suppressed. So, for example, the FDA removed the emergency use authorization for the use of hydroxychloroquine, and right after that, gave remdesivir in that approval. Even though remdesivir was only for inpatient use, and its benefit at that time, which was the basis for the emergency use authorization, was that it reduced hospitalizations supposedly by 30%, from 15 days to 10 days. Didn't even affect mortality. However, if you look at the kind of the final data right now, remdesivir is a very dangerous drug. 6% of patients that actually took it developed dangerous arrhythmias, atrial fibrillation, for example. I'm just, that was the whole propaganda against the use of the safe hydroxychloroquine, that it's going to cause people to die from arrhythmias. In reality, after speaking to a group of 3,000 electrophysiologists, there were 0 reported cases of any fatal arrhythmias in the outpatient setting, which is not the case with remdesivir, which 6% of patients develop atrial fibrillation. So the hypocrisy, don't get me into the politics here, but the hypocrisy of the medical field is at fault here for much of the death. So, for example, the Lancet study is retracted for fraud. The recovery trial used homicidal doses of hydroxychloroquine, Solidarity trial as well. And most of the other studies that showed negative results were done on ICU patients on the ventilators. And then from that, they extrapolated that the outpatient regimens won't work. I don't see how you can extrapolate from the ICU to the outpatient center. So there was a lot of orchestrated negative propaganda to try to stop the spread of this life-saving information. I just got an email just now that this is kind of breaking news. AMA just changed its policy, American Medical Association, because they came out 3 months ago with a recommendation against the use of hydroxychloroquine. Now they just came out, they rescinded that recommendation, meaning now it's okay to use in an outpatient setting. Just now. That's where I'm talking. I'll forward that to you guys. So the hypocrisy here is, we have to, in the future, figure out why that happened. But I think we all have our theories. But hopefully the focus should be right now in ending the death.
And if I may mention the US situation with, and probably I saw this graph about Germany, and it seems that mortality is rising. Is it in hospital mortality? Is it in elderly homes? Do you have any details about the pressure on hospitals right now in Germany?
No, I mean, usually it follows the, let's say, the age. But also hospitals reporting more and more younger patients, right? Making also the society aware of that there is a certain risk, and of course that ensuring that you don't contract the disease is very important at the current stage of the pandemic, having, as they say, no other opportunity available, and this is primarily hospital deaths to our knowledge. Yes.
And what is your ability as prominent researchers to influence the German authorities and maybe the European authorities? From my perspective, it's so obvious that everything needs to be done to avoid the pressure on the hospital. So outpatient treatment is the obvious solution there, and the protocols exist, and your experience with Dr. Zelenko's treatments in New York, but you have also a lot of evidence now on ivermectin-based treatments. So this concept of reducing hospitalization seems to be, from my perspective, from a policy viewpoint, is paramount. But how to get the message through at the level of the authorities? Can you comment on that?
I mean, based on my experience, and I'm sure Vladimir has a comment as well, communication and education is needed. I mean, we had the data from Marseille, for example, and a lot of other emerging data demonstrating that the earlier you treat with hydroxychloroquine, and especially in combination with zinc, the bigger the benefit you see. And this really needs, unfortunately, as often in medicine, and there are a lot of examples in history, a lot of time. Unfortunately, we don't have time in the pandemic, and I think we clearly see that the system that was in place, including almost every stakeholder in our healthcare system, academia, and science, has not been prepared for such a pandemic and how to manage it, I would say, on the go. And to continuously update recommendations and looking into every direction. I mean, the discussion, for example, that only randomized controlled double-blind trials are valid. I mean, this is it is also just not true, right? I mean, when you see in observational trials huge treatment effects, at least this informs further research. And this was also not happening. It was about then opinions after data was out for totally different subgroup of patients, as Martin Scholz and Vladimir Zelenko just commented on. And it was never revised, by the way, right? I mean, we saw a lot of news when this data was coming out. I mean, there was a second paper published in New England Journal of Medicine based on the same database, like the one in Lancet. And the paper were withdrawn, but there was not a lot of noise and it was not really corrected in public. And that is, of course, unfortunate. So it goes step by step. I think also webinars like these ones will help, but there's a lot of communication and education needed, for sure. I don't know, Vladimir, do you have any additional comment?
I was told not to get into politics, so I'll have to be careful. But I think the hearing is tomorrow, the Senate hearing about early treatment. Senator Ron Johnson organized it, and he's the head of Homeland Security because it's a Homeland Security issue. And there's going to be some prominent doctors testifying, one of which is Dr. Harvey Risch, the MD, PhD from the Yale School of Medicine. His area of expertise is epidemiology. So he actually commented that that a meta-analysis of observational studies is sometimes significantly more statistically powerful than randomized controlled trials. And sometimes RCTs are completely unethical and inappropriate. You know, the famous, I think Dr. Derwent told me about parachutes. We want to do a trial on parachutes. So we're going to randomize two groups and send half of the people out to the plane without parachutes. So obviously not. So there are times when it's inappropriate. And in a time of war, you know, I like to use World War III as the appropriate analogy for this. Over 200 countries are dealing with this same viral infection. So I don't know how else you would describe it. And when you're dealing with such a global crisis, to waste time, and the word here is waste time on treatment to get randomized controlled trial data is inappropriate. You can do it in parallel, but use the best information now. So I think that, I'm sorry, I think that this randomized controlled trial business was used as a smoke and mirrors, as a power grab and control grab by people like Fauci, who want to monopolize the flow of medical information and truth.
I have here a question, less political. Mea culpa, I'm the one who have suggested to keep the politics outside the webinar. Here is a question regarding zinc. How to find out what is the concentration in elemental zinc when typical preps sold like gluconate, picolinate don't make it explicit?
So I have some information on that. I know that zinc sulfate is 23% zinc. So the key in treatment is, even though there's significant differences between the salts, we want to get around 50 milligrams of elemental zinc. That translates to 220 milligrams of zinc sulfate, for example. Take 23% of 220, you'll end up getting 50 milligrams. Zinc gluconate, I believe, is 13 or 14% elemental zinc. But at least in America, the supplements that I've seen, picolinate and citrate and the others, they do tell you how much elemental zinc is per pill. So it's not that complicated.
Do you have any suggestions regarding which zinc, so you know, which form of zinc to use?
No, I found that some people tolerate some better than others. You know, there's no such thing as elemental zinc in a pill. It comes as a compound. So when you absorb it and dissolve it into solution, that's when you get the elemental zinc. So the delivery of the elemental zinc, the requires a compound. And some people are allergic to sulfate or whatever. So it's important to remember that if you can't tolerate one formulation, you may very well tolerate another.
Dr. Scholz, Dr. Derwan, do you want to comment on this?
No, I think it's important what Vladimir said. It's very individual. I mean, the lower concentrations, for example, or let's say the daily dose of 10 milligram, average daily dose, you find in many mixed supplementals and tablets. I know there are formulations people, as Vladimir said, has issues with when they come as a tablet. And maybe for these patients, it might be interesting to see if they find zinc in the form of a capsule as well, because they have less issues swallowing then often. And this is just a hint, but you can find out. I have, my personal impression is that if such a supplement comes as a capsule, often it is easier to swallow and probably tolerate.
Okay.
Maybe I can add something to it. I would recommend. I find an interesting review. It's by Reed, R-E-A-D et al. It's from 2019, and it is the role of zinc in antiviral immunity. And it shows very nicely the complex situation of the zinc metabolism. And for example, it's to give an example. It's 10 to 18 micromolar. It's the normal range in plasma. It's to have antiviral effects. It is in the millimolar range, and in intracellular, it's pico and nanomolar range. So, and we have, as I mentioned before, we have the situation when it comes to inflammation, hyperinflammation. The binding of zinc will change. So the zinc, at the end of the day, the zinc has to come through the cell, and this will be enabled by zinc ionophores such as hydroxychloroquine or quercetin. And so what kind of zinc product will be the best? It's I think it's too early to comment on this, but maybe it's more important to look at the timing of zinc application.
And maybe just to add, I mean, we talked about evidence. I mean, here, as I commented before, I would go with the available evidence, and a lot of evidence is there for zinc sulfate, for example, and it is available. You can get it.
Okay, I'd like to conclude. We are at this point not really having questions, at least the ones that are really focused on the content of the webinar. But I would like to ask you, and starting with Dr. Zelenko and then Dr. Scholz, to give you some final conclusions of this session. You see, if you final comments, Dr. Zelenko.
So I think that what made our collaboration so successful, and I consider my colleagues my friends now, is that it wasn't really about ego. I'm not experienced with academia, but now that I've had to deal with some academic physicians, I find that everyone's positioning themselves for a Nobel Prize. So I would just like to say that our collaboration is a very unique synergy of, like in the case of Dr. Scholz, academia, Dr. Derwan, industry, and in my case, clinical medicine. And each one of us brought a unique perspective to a problem, and we were able to put together something that is really significant, and it lays the foundation for future research, and more importantly, it brings to the world a treatment approach that will, in my opinion, stop this plague. So, so I want to say thank you to my friends.
Thank you. Dr. Scholz?
Seth, thanks a lot for these words. I can also give it back to you. And we don't have all of us, we don't have any commercial benefit out of this. And so we all three did this study, and it was a lot of work during the last couple of months. we did it all because we wanted to do anything, because we had an idea, or Roland had the idea to put these zinc and hydroxychloroquine together. Zef did it. We didn't know this before, but Zef did it already in New York State. And so we started naive with the idea to help the patients and to avoid the hospitalization and mortality. So that's all. And my conclusion would be, we should go on now with a sort of prospective study to show the people that it's not the people who say that, okay, it's only retrospective and it's not randomized, etc. We should bring together the outpatient doctors, the practitioners, and who should try this treatment, this triple therapy, in a sort of prospective way. This is my point, my conclusive point.
Thank you so much, Dr. Derwent.
Yeah, no, thank you to everybody. And I mean, obviously, we were driven somehow by, I would say, a similar objective, as Vladimir Zelenko said, from different perspective, of course, where we are coming from. I mean, at the beginning of my presentation, I told you that just a few kilometers where I'm sitting now, the first patient was diagnosed with SARS-CoV-2 infection. So basically, that happened in my neighborhood. And unfortunately, in the course of the pandemic, these cases came nearer also to my environment and friends, and unfortunately there were even some deaths. We all had the interest, maybe with our work, to put a small piece to the puzzle. It was almost a miracle then to meet Zef after we worked on our hypothesis paper, and all these dots then connected somehow in the future, ending up in the analysis and publication, what he did with patients, really helping them. I think what is important, we have science and medicine, and of course these days medicine is more and more, and that's absolutely important and also beneficial to the patients, driven by science. But this pandemic has shown that here it has to go much more hand in hand. You need to do something for the patients now, and you need to develop the science in parallel, and we cannot just stop. I told Vladimir Zelenko once, if there's a big bleeding in medicine, you first put a finger on it. But we do not discuss about a randomized controlled trial. We will do that to ensure that in the future we do better, probably. But this discussion and approach I missed a little bit, and obviously our society and world was not really prepared. And let's see what the learnings are now and tomorrow, to be honest. And if we are hit in the future, hopefully not, but if we are hit again by such a pandemic or issue, and we can only hope that we learn from the mistakes we did during the last weeks and months, and that patient can benefit soon in the future, hopefully even before vaccine is available, but also after a vaccine is available.
Thank you. Dr. Zelenko, Professor Scholz, Dr. Derwent, and I have to thank you so much for having accepted to participate in this webinar, and I have to thank all of you who watched it and asked questions, participated, and the session will be available online soon on our website, covexit.com, and I will urge you to share it widely, so this information is available to everyone very shortly. So thank you so much again. Thank you.
Thank you.
Thank you.